Good morning, ladies and gentlemen. I welcome you all to the milestone session of today's AMACON 2024, that is the Dr. B.L. Agarwal oration, to be delivered by our chief guest speaker, Padma Shri Padma Bhushan Dr. D. Nageshwar Reddy, with session chairpersons, Professor Dr. D.K. Nigam, Dr. Ashok Agarwal, and Dr. Anil Shukla. We have our session chairpersons on stage, Professor Dr. D.K. Nigam, Emeritus Professor Medicine and former Director, Professor and Head, PG Department of Medicine, Motilal Nehru Medical College, Allahabad. Dr. D.K. Nigam has been National President and Founder Member of Society of Gastrointestinal Endoscopy of India, and he has been President and Founder Member of UP Chapter of Indian Society of Gastroenterology. Dr. Ashok Agarwal sir, he is Senior Consultant Surgeon and past National Vice President IMA. Dr. Anil Shukla, Senior Consultant Pediatrician and past President Allahabad Medical Association. I invite our distinguished speaker for the session for the Dr. B.L. Agarwal oration, Padma Shri Padma Bhushan Dr. D. Nageshwar Reddy, on stage for his lecture. I will request Session Chairperson Dr. Anil Shukla sir to please remember Dr. B.L. Agarwal to this audience.
Thank you, Dr. Parul, and good morning, ladies and gentlemen. It is indeed a great privilege for me to honor the memory of my respected teacher, the late Professor B.L. Agarwal, in whose remembrance this prestigious oration will be delivered by Professor Nageshwar Reddy today, and highlights some notable achievements of his long and distinguished career. Professor B.L. Agarwal was born in 1922 in a professional family in Moradabad. After completing his preliminary studies, he came to Allahabad and was selected for PMT in 1940. He graduated with MBBS degree from the state's then only medical college, the King George's Medical College, Lucknow. In 1946, he started his career with the Indian Army Medical Services. Soon after the surrender by Japan towards the end of the Second World War, the Allied forces constituted the British Commonwealth Occupational Force, the BCOF, and Dr. Agarwal was selected to represent India as a medical consultant. He landed in Japan just a few days after the atom bombs were dropped at Hiroshima and Nagasaki in August 1945, and was specially deputed at the Army Base Hospital, where he rendered yeoman services to the suffering humanity, vigorously treating patients of the atomic bombs that had devastated the two cities, and continued there for the next 2 years. He actively participated in the Kashmir operation of the Indian Army in 1946 and 1947 upon his return to India. In 1950, he proceeded to England and was awarded MRCP in 1952. On returning, he served the Lucknow and Kanpur medical colleges before joining Evelyn Medical College, Allahabad, as the head of Department of Medicine in 1963. In 1969, he was awarded the FRCP in UK, and in a short span of time, he rose to be the Director, Professor, and Head of Department of Medicine, a post he retained till his retirement in the year 1983. Two prestigious awards of the field, Dr. B.C. Roy National Award for Outstanding Contribution to Medicine and Hari Om Ashram Award for Research, have been conferred on him by the Medical Council of India. He had an abiding interest in rheumatic fever and rheumatic heart disease and contributed much research on the subject. His research was also published in the prestigious International Journal of Medicine, The Lancet. He had the honor to be the distinguished speaker at international conferences at London, Tokyo, Washington, Bangkok, Taiwan, and Kuala Lumpur. After retirement, he was designated as Emeritus Professor of Medicine by UP government. He continued treating patients after retirement and ran a polyclinic at RK Mission, where he provided medical services to the poor free of cost. He passed away on February 22nd, 1998, after a brief illness while serving humanity till the very end. Thank you.
Thank you, Dr. Anil Shukla. I will request Professor Dr. D.K. Nigam sir to please introduce the speaker to the audience.
Hello, ladies and gentlemen, I have got great privilege to chair this session because of two main factors. Number one, because since it is in the memory of Professor B.L. Agarwal sir, I am really indebted to Professor B.L. Agarwal sir because he was the head of partner at that time, and he gave me full opportunity to set up a GI endoscopy setup right in 1975. At that time, I think it was a primitive endoscopy setup in our country. He gave me full opportunity from that point of view. As far as the second factor, because Dr. Nageshwar Reddy, who is an international figure, I am chairing his oration. I knew Dr. Nageshwar Reddy right from 1990s, as I was one of the executives in the national body of endoscopy. And I saw, I'm not at all exaggerating, that out of the video presentations of endoscopy work done by the gastroenterologists at that time, Dr. Nageshwar Reddy's video presentations were excellent, I mean, I really so impressed at that time in 1990, especially his endoscopy techniques of hepatobiliary region, especially the biliary region from that point of view. As far as Dr. Nageshwar Reddy is concerned, he has now reached a international chair, as I said, because he has become the president of World Organization of Endoscopy. It's a great thing for us, for all of us, for our Indians. He has acquired that chair. And by that time, and the second important thing is this, that he has got almost all the national awards, I would say. He has got B.C. Roy National Award. We are clapping for him. He has got a national award, a B.C. Roy National Award. He has got a Padam Shri. He has got a Padma Vibhushan also from that point of view. He has established the Asian Institute of Gastroenterology, known as famous AIC in Asia, which is one of the best centers, if I could say, in Asia and also in the world, no doubt. And a lot of cases are being referred to centers, and it's a great center, well-known center in the world, that there the research and the clinical patients' care and treatment is being done in the same particular fashion. It's an honor for us from that point of view. He has been members of the various fellowships of various societies also, actually, all the national societies, prestigious fellowships of reputed national and international societies of gastroenterology, especially. You can see the biodata just in front of you. I need not narrate all of them, but you can see how popular he is and how famous he is. Has made a dent in the American Gastroenterology Society from that point of view. So with these humble words for Dr. Nageshwar Reddy, I would now very affectionately and very humbly request him to please deliver his oration on endoscopy, metabolic endoscopy. Thank you. Dr. Nageshwar Reddy, please.
Thank you very much, sir. And again, I'd like to thank the Allahabad Medical Association, especially Dr. Rohit Gupta and others, for giving me this kind opportunity to be here this morning to deliver Professor B.L. Agarwal's oration. Again, like you said, I have two reasons for being very happy about this. First of all, Dr. D.L. Agarwal, I think, was one of the pioneers in medicine in this part of the country. And I published a paper in Lancet so early on is a remarkable thing, because it is extremely difficult to get a paper into Lancet, even now, to do it at that time. So to his family, I'm grateful that they are here. And second reason is because of you chairing the session, sir. Dr. Nigam, I used to know him as a medical student. I was an undergraduate student in 75 when he started endoscopy. And I was, in fact, in SGI for some time, and I remember listening to his presidential, he was the president of Society of GI Endoscopy of India, one of the very early persons. And usually it used to be from Delhi, Bombay, Chennai, and also when somebody from Allahabad became the president, people started looking at where is Allahabad, where is the president coming from. So this is, I think, a milestone we have done. So for me, it's, I think, to be here on this occasion is very important. So my topic is on metabolic endoscopy. Endoscopy now has been very subdivided. So I think when Dr. Nigam started upper GI endoscopy, or when I started doing endoscopies in 83, 84, we would think that endoscopy was only for diagnosis of GI problems, maybe for treatment at that stage. Slowly we knew that we started treating early gastric cancer, pancreatic biliary disease, and so on. We never imagined that endoscopy would become important therapy for metabolic diseases. And so my heading, metabolic endoscopy, may look a little strange to you, but what I do over the next few minutes is to explain the physiological basis of why this is being so, and how endoscopy is going to become an important tool in future for metabolic disease. Let me start with this metabolic syndrome. We know now that the biggest epidemic in medicine is the metabolic syndrome that we see. It's a combination of diabetes, obesity, with of course non-alcoholic fatty liver disease and other things like hypertension, hyperlipidemia, and so on. All these combinations metabolic syndrome. And these three pandemics together are affecting hundreds and millions of people all over the world. Three chronic, poorly managed diseases. All these diseases, obesity, diabetes, NFLD, although we think we have treatment for diabetes, we have some treatment for obesity, we don't realize that we don't have proper treatment. And in fact, as the incidence of these diseases are becoming more and more, the need for developing proper therapies are coming in. In 1902, Dr. Jackson, who was the ENT surgeon, very accurately predicted that if some non-invasive or less invasive therapy like endoscopy comes, then everybody will opt for it than open surgery. And this has become true now, as endoscopy is going more and more into the frontiers of bariatric therapies and surgery. So when you talk about metabolic endoscopy, there are two areas. You combine both bariatric and metabolic together. The first area is you have gastric restriction. Gastric restriction, of course, is to decrease intake of food, decrease obesity, decrease all the metabolic problems that occur with increased food intake, nutrition. The second is the small bowel area, where we now know that small bowel is a very important area for metabolism, and you can actually do things to decrease. So let's start first with this. In fact, what we do as endoscopists for the last few years is a temporary method to decrease obesity. Put in gastric balloons for 6 months. When you put a gastric balloon, a simple half-an-hour procedure, outpatient procedure, the patient starts losing weight. And in addition to losing weight, what happens is, many of these patients, you can see here from this very important study from Singapore, that the liver fat goes off, the triglyceride level comes down, and diabetic control improves. But unfortunately, this is a very temporary way of doing it. If you actually look at other techniques or technologies available, you can see that we have surgery, gastric bypass surgery, the metabolic surgery that became very famous in the Western world at one end of the spectrum, and diet, exercise, and medication at the other end of the spectrum. So as it becomes more invasive, less patients go for these types of surgical therapies. So we require something in between. And in between became the endoscopic therapies, the intragastric balloon, and endoscopic sleeve gastroplasty. So let me again briefly talk to you about this. I know this is a very technical topic, but What we do in endoscopic sleeve gastroplasties is endoscopically stitch the greater part of the stomach, the greater curve of the stomach, so the stomach volume is reduced, and these patients tend to eat less. It's equivalent to laparoscopic sleeve gastrectomy. What happens is, this is an organ sparing surgery, so many patients prefer this rather than surgery, and you can see very clearly the stomach is stitched here in the greater curve. It becomes very small, and the food gets located in the fundus of the stomach, not going down, and these patients have satiety, eat very less. And it's quite effective, and we're seeing that it reduces weight, but what effect does it have on metabolic problems? It is very clearly shown that using this, we can actually dramatically treat patients with non-alcoholic fatty liver disease. The fat comes down, to some extent the fibrosis comes down, to some extent only. So hepatic steatosis is mainly indicated. And this is a study that we did in our hospital, published recently, where we showed that if you do sleeve gastroplasty at ESG, compared to pre-endoscopic versus post-endoscopic, you can see dramatic reduction in all hepatic parameters. All the abnormal metabolic parameters in the liver are reversed to a large extent by 6 months. And as we follow these patients for 3-4 years, we find that many of them lose the fat in the liver, some amount of fibrosis coming down. So this is an effective way of treat metabolically when there is a combination of obesity with a metabolic problem. And this is the famous MERIT study in Lancet, which followed a large number of patients after doing endoscopic sleeve gastroplasty, showing that not only is obesity treated, but the metabolic problems can be treated. So this is one way. And now, because of availability of variety of drugs, in fact, we have semaglutide, you have Manjura and so on. All these drugs are being combined with sleeve gastroplasties, very effective way, so that bariatric surgery is taking a very secondary role. It's now a combination of endoscopic metabolic surgery along with drugs, which are very effective. And I think this is going to be the new way to treat many of our patients. But now let's look at the other problem, and that is the small bowel. Now, why this has become very important is that we now know that many of the metabolic problems that we have, diabetes, for example, type 2 diabetes, hyperlipidemias, polycystic disease ovary, all of these are because of insulin resistance. Now, this insulin resistance could be because of obesity, or very peculiarly in non-obese people also start having insulin resistance. So you have lean diabetics, you have lean fatty liver disease, because they have a genetic insulin resistance resulting in this metabolic problem. So if you have insulin resistance because of obesity, technically using endoscopy you can decrease it. But can we also treat insulin resistance without obesity? And this is where the surprising facts are come. Yes, we can endoscopically treat. Because if we don't treat, these patients can go from non-alcoholic fatty liver disease to NASH, cancer, cirrhosis, and so on. But we have an effective method to prevent this. How do we do this? There are many endoscopic techniques available, but before I go into this, I want to show you this dramatically changed concept in physiology that has occurred. We all used to think that the central control for glucose hemostasis is pancreas, right? Pancreas secretes insulin, pancreas secretes so many other GIP, so many other factors which control sugar. That is what has been the physiological thinking. This thinking now has been shown to be wrong. Pancreas is not the central control. Pancreas cannot be central control because the first contact with food for human beings is the small intestine. So nature has created a mechanism where the small intestine is actual control, the pancreas is the secondary control. So all these years we're focusing on insulin amounts and pancreas and so on, but that's not the control in the small intestine. And this is metabolic brain is in the small intestine. As an endoscopist, we can go into the small intestine, insert duodenum, and control the metabolic process. This is the beauty of the thing. So let me just again show you in a cartoon of what happens. When we eat food normally, the food goes to the small intestine, and as it's going to the small intestine, it stimulates these incretins and anti-incretins. Of course, there are now names for all of this. And because of the stimulation of anti-incretins and incretins, the sugar levels are maintained in a proper level as sugar homeostasis occurs. The anti-incretins are now named as insulin resistance factor or diabetic insulin peptide and so on. But whatever the name, the sugar euglycemia is maintained because of interaction of these two as the food is passing through the intestine. The secondary pathway is like stimulation of insulin and so on, that's different. Now, what we have started doing over recent years is take very refined food, and the chocolate is an example of this. As we take refined foods, the sugar levels can go dramatically up and can come dramatically down, producing hypoglycemia. To prevent this, the body naturally develops more anti-incretins. And as the anti-incretins increase, there is insulin resistance. And because of insulin resistance, there is increased blood sugar, increased triglycerides, increased fat in the liver and NASH. So this is the whole physiology we understood well. There is a lot of animal work in this area, a lot of women, but I just simplified this in this cartoon. So this insulin resistance ultimately results in type 2 diabetes, NASH, polycystic ovarian syndrome, coronary artery stroke. Everything is related to this central mechanism. So if we can control insulin resistance, get insulin sensitivity into the body, many of these diseases can be controlled. And how can we do that? I'll show you some examples. And again, a lot of work has come from labs in UK and US, which are actually, there are more than 50 labs now working in duodenal endocrine systems. A lot of data is available which has shown that from the duodenum there are several endocrine cells secreting different hormones, and diabetic insulin factor is one, the diabetic resistance factor is one of these which are being secreted. So people are trying to identify this peptide, and soon I think we'll identify this peptide. So studies have shown that if you actually take biopsies from the duodenum of a type 2 diabetes who is not well controlled, you will find a large number of these enteroendocrine cells in type 2 diabetes compared to normal people. So these neuroendocrine cells we knew were there, but quantification occurred now and to show a large amount. And similarly, if you take rats and feed them Western type of chow, high calorie and less fiber diet, you can see what happens in their submucosa. A huge number of neuroendocrine cells come, showing that this is a dynamic process. Actually, in humans, we knew this was happening, but we didn't recognize it till recently. If we do a bariatric surgery, a Roux-en-Y gastric bypass, where food is bypassed the small intestine and goes directly into the distal part of the small intestine, these people don't lose weight immediately. They take, say, 1 month, 2 months to lose weight. But what happens immediately is dramatic hypoglycemia. Third day, fourth day, they're going to hypoglycemia. We sometimes have to even stop insulin in these people. This the surgeons knew, but we didn't know why this was happening. And now we know why this is happening because of this fantastic work done by Cummings and all, published in 2004 in Annals of Surgery. And look at this carefully. What they took is they took people who were severely obese, type 2 diabetes, did a Roux-en-Y gastric bypass. So the food was not going into the duodenum. And they did a hyperglycemic study. So these people, to start with a hyperglycemic, they did Roux-en-Y gastric bypass. So when you do this Roux-en-Y gastric bypass and people started taking food, you see food was passing down, not going into the small intestine. In 2 weeks' time, these people became normoglycemic. The sugars became normal. Nothing else was done. No other drugs were given. And what they did was, they took permissions from the ethical committee and put a gastrostomy tube, feeding gastrostomy tube in the stomach. And the patients then started feeding from the mouth and also gastrostomy tube. So the nutrients are going to the duodenum. And immediately nothing changed. They became hyperglycemic. They became hyperglycemic. And when they removed this tube and oral feeding, they became normoglycemic. So very nice experiment. It clearly shows that the duodenal nutrient passage strongly influences insulin sensitivity. So there is some factor in the insulin, insulin resistant factor or whatever that's being secreted from the duodenum, which is causing all this insulin resistance. And the actual insulin secretion from pancreas is secondary. So can we control this? And this is a very important concept that has changed the thinking. The first realization came when colleagues of mine actually in South America were putting this endo barrier. They actually put this long silicone tube endoscopically, so the stomach food comes in, bypasses, goes into the distal part of the jejunum. They were using this for obesity treatment, not for anything else. This was incidental. And when they're using Cobis, they found surprisingly that this did not reduce the weight much. Patients reduced 5%, 6%. But what was happening is, all these patients, some of them, many of them type 2 diabetes, the diabetes is getting reversed. So this was a very unusual finding they found. So based on this, we now have what is called duodenal mucosal resurfacing, where endoscopically we can go inside, put a endoscope in the small intestine, and using hot water balloon at 80 degrees, we can actually burn the mucosa here, submucosa to some extent, leaving the muscle intact. So we inject some fluid into submucosa to protect submucosa, and this balloon can go inside and starts burning the mucosa of the duodenum from D2 to D4 to burn it. So this is a technique that came in recently, and this was the technique actually you can see it endoscopically. I had a fortunate opportunity to work with this technique at Elasme in Jack Davies unit. It's a fairly simple technique, any upper GI endoscopist can do. You look at the balloon, saline is injected, and then you inflate the balloon and put 80 degrees hot water into this. And when you put this, the mucosa gets burned. And what is good about this is the mucosa that gets burned, about 3 weeks time, it gets regenerated. By 3 months, it's normal. The mucosa is normal, but histologically, when you take biopsies from these mucosa, you find that there are no more neuroendocrine cells. All the neuroendocrine cells have been destroyed. So the insulin-resistant factor secreting cells are gone with this technique. And you can see the results. They published the first study called the Revita study, showing that by doing this technique, A1C drops 1.5%, HOMA-IR improves. Of course, the liver enzymes also improve. So this was the first study. And then they subsequently showed in a randomized, of course, you want to do a randomized control study to prove a point that this is good. In a randomized control study, they showed very clearly that compared to a sham procedure, this can result in remarkable decrease in A1C and also the liver fat, which is measured by MRI. So you can see the difference. So diabetic control in patients are not controlled by standard diabetic techniques were done with this methodology. So this was a technique, and you can see this is a sort of a combined study from different units which showed that all the metabolic parameters were being controlled by this technique. So just by simply destroying the duodenal mucosa from D2 to D4, all the metabolic parameters, you see that the A1C comes down, ALT improves, and then of course you have lipids all coming down, triglycerides come down, and antioxidant capacity increases. So this was a remarkable finding which changed the whole concept on the physiology of duodenum and physiology of metabolic processes. So can we change the liver NASH also to some extent? We have found that using this you can also control the liver fibrosis and the steatosis in the liver. The problem is this is not, it looks very easy endoscopically, you can do it, but it's not very pleasant. You to take some time, hot water is a very crude method and all. So newer techniques are developing using laser, RFA and electroporation. And this is again a very interesting area where you can actually use this. We are now starting to use this electroporation. And we are involved in the research study where a very simple device like this is an electroporation device where the cardiologists use for electroporation for their cardiac arrhythmia. Same thing can be mounted on a catheter. We can actually watch it now endoscopically. This opens up and produces electroporation. It means just produces holes in the cell, no burning. Just holes in the cell, and this mucosa, to some extent lamina propria, completely degenerates and some amount of submucosa. So all the neuroendocrine cells go, and compared to a thermal ablation with hot water, this is much more safer because there is no injury to the tissue. So this is a technique that has come up, and this is again Dr. Barham from Mayo Clinic who is working with us, who has actually started this technique. And you can see this is a very unique technique where high voltage electrical pulse produces holes in the cells, a controlled depth of penetration, so only the mucosa, submucosa, and of course you can, 100% of the patients are successful. There is no failure rate in this treatment because such a simple technique, average endoscopists can do it, that's the beauty. And you can see that within 24 hours, the cells are completely destroyed, but within 3 weeks they come back. But the difference between this mucosa, and this is that there are no neuroendocrine cells, they're destroyed completely, and that's the major difference that is there. So of course now we know that using these techniques we can actually make an insulin resistant mucosa into an insulin sensitive mucosa, and that is the whole basis of the metabolic syndrome, insulin sensitivity, and the whole basis is in the duodenum, which can now be altered. So there are two very good studies recently published, which have shown the efficacy of this using this electroporation. And you can see here, this is a study from Balham's group, who actually took patients who are 100% dependent on insulin, type 2 patients, 100% taking insulin. After this therapy, 12 months, 86% were off insulin, only 14% required insulin. This was very interesting. And of course, there's a 50% reduction in liver fat, all metabolic parameters improved. And this is called the RESET study, which they recently published, showing it's just actually a few months old now, showing how effective. And similar study called the EMINENT study, which was done by a group in Amsterdam, the Dutch group, again showed that you can do reset, no mucosal damage, and again they showed something very similar. 100% of patients on insulin, only 86% can be completely removed, only 14% remain on insulin in the end of study. Showing exactly similar results, showing that you can duplicate these studies. We now have a large ongoing study in AAG where we are looking at animal work on this to see how effective this is. So you can see the more important thing for us as gastroenterologists is the fat content comes down from very high levels. And these are again very remarkable MRIs that I borrowed from my friend Jack in Amsterdam. And you can see that baseline fat by this MRI, we actually do a fat, how much fat is there by MRI. It's a very proton density fat fraction it's called. And you can see this, it's 23%, which is very high. Normal fat is only about 2 to 3%. But after this procedure, the fat has come to 2.8%. Again, it's a big metabolic control has occurred because of this phenomenon. This is very remarkable. So we are now trying to develop other methods, and this is Dr. Vikesh Sharma from US, who's again we're working with, who's developed this very simple technique, an umbrella, between which you get put steam in between. The steam destroys the mucosa in a very controlled fashion, and again, the depth of injury is very controlled. That has been shown to be very effective in some group of human beings. We are getting a little bolder as endoscopists, so can we create like a surgical anastomosis, endoscopically create anastomosis? And this is a very interesting concept which we are doing, where endoscopically we are now doing ultrasound guided gastrojejunostomy. So you can do a gastrojejunostomy very easy. You can also put a plug into the pylorus so that the food now, instead of going down, is going to this area. This is the early concept that's coming in, mechanical. So these are all the ways in which endoscopy is actually altering the whole metabolic syndrome. So I believe that the future of treatments in metabolic syndrome are going to be a combination of drugs that are available and endoscopy. For example, if the patient is obese, we would do an endoscopic balloon or a gastroplasty. The patient is lean, we do an endoscopic DMR. This can also be combined. Whatever it is, we come back to what Dr. Nigam was doing in 1975. It's a simple upper G endoscope. We can control a major epidemic that's occurring in this world, the metabolic syndrome. The future is very bright. Of course, this requires a lot of people involved. We have a great group at the AAG. You have metabolic scientists, surgeons, endoscopists, physicians all working together. And I'm sure that this is a problem that is the biggest problem for Indians compared to any other country. We have the largest metabolic syndrome concomitants, and I'm sure that we should be able to solve this very quickly with this combination of therapies that we have. Thank you very much for your attention.
To please honor and felicitate the speaker and the chairpersons. I will ask Dr. Rohit Gupta sir, organizing secretary, to please join Dr. Kamal Singh sir. I will request Dr. B.L. Agarwal sir's family to please come on stage for honoring the speaker and the chairpersons. Dr. Yash Agarwal, Dr. Sonal, Mr. Vinod Kumarji and Mrs. Manju.